Magin here at Duke Spine Institute. We're getting ready to perform Duke laser disc repair lumbar. That's the lower back. We call it the lumbar spine. That's the lower back part of the spine. And most likely 3 levels, but possibly 4. We're going to test L5S1. There's a small herniation at L5S1. The patient's symptoms seem to be more from the L2, 3, 3, 4, 4, 5. But L5S1 we can't exclude based on physical exam, and there's certainly a small herniation, an annular tear, and a high intensity zone, HIZ, on the MRI T2 weighted image. So we'll be testing it. What is it, afternoon now, right?
Yes, sir.
Good afternoon. I'm Dr. Duke Magin, I'm here. We're going to get started. Are you comfortable? All right, I'm going to give you some medicine to numb things up, okay? And you're going to feel a little stick and burn. That's normal. Don't be afraid. If you feel any pain, just say ouch, okay? Just don't move around. Deal? And I'll give you some more pain medicine if you say ouch. All right. Little stick and burn, that's normal. That's the medicine going in. That's your pain medicine, okay? Fair enough? So we're going to start by numbing the skin. And once that's done, this is going to be one of the worst parts right here. So once we get you through this, you're going to feel better, okay? So don't worry. Now I'm going to try to do everything through one incision. Remember, you just let me know if you feel any discomfort, okay? The first step here is going to be gaining access to the disc space. Shot. Let's try to center. Now our patient has some scoliosis. We're not here today to fix scoliosis. We're here today to treat her back and leg pain. She doesn't really have much leg pain. She's about 98% back. Shot, that's it. Let's go lateral. But her back pain is more on the right side. It kind of radiates into the right hip and buttock area. It was something. A little something, something. All right, so it's a nice trajectory for L5S1, which is a good starting point. We're going to test L5S1 anyway. Shot. Shot. Are you comfortable? Shot. It's a little too high. Shot. Shot. AP. So the first step in the surgery is to gain access to the disc where the herniation is, on the side of the herniation, through a transforaminal approach. That means through the foramen, the neuroforamen specifically. So there's a natural opening within the spine in everybody. It's called the neuroforamen, lateral. And that opening is actually where the nerve comes out that goes down the leg. And everybody has those holes in their spine. It's kind of on the side of the spine. And that's how we do the surgery, is we go through that natural opening. Shot. Where do you feel that? Shot. Where do you feel it? In your back. Right? In the back? Shot. All right. Is it better? Shot. So we're definitely rotated here. Shot. 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 You feel it anywhere? Shot. AP. I think we're too lateral. So there's the medial border of the pedicle, medial border of the pedicle. It's pretty good actually. Go back to a lateral view. You might be able to sneak maybe another degree. Shot. 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 You feel it anywhere?
My right side buttocks area.
Where?
My right side, like buttocks area.
The gluteal area.
All right. Let me try AP. By the way, you're doing really well. I'm sorry you have to be awake for this part, but it's really quite necessary. And we don't do that just for you, by the way. We keep everybody awake for this part. Did you get the AP? That's it? So, shot. Lateral. When patients have scoliosis, their spines are twisted. And you can see there's definitely twisting, and it's still possible to do the surgery. We've done it many times on patients with scoliosis, but you have to account for the scoliosis, which makes it more challenging. Where do you feel it? In your back. Shot. Shot. In the back. Shot. You see we're getting caught up on the facet joint. Shot. 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 Where do you feel it?
My back. My back.
Shot. Not down your leg?
Um,
It's okay. I don't expect you to, but I'm just checking. Huh? Yeah, I see that. Shot. The collapse part doesn't bother me as much as the rotation. Shot. Yeah. You know, Santiago, I think you could have been a neurosurgeon had you wanted to be. Not that you would want to be. Had you wanted to be. Right? You probably are a little bit smarter than the neurosurgeon. I realized why. Shot. Why would anyone want to do that to themselves? Why would anyone want to do that? Shot. 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 We're very close. Sorry about that. Shot. 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 Where do you feel it? AP? So you can see I have everything in position at 4-5, 5-1. We're going for 3-4. And 3-4 is very collapsed. She and I looked at the film before surgery and there's a lot of edema in the bone. Yep, that looks good. Back to a lateral. And of course, looking at that space going, my God, that's so collapsed. And yeah, nobody said the surgery is easy. That's why surgeons don't do it. They don't know how to do it because it's very difficult to do. It doesn't mean I give up. I'm not the kind that gives up easily. I only give up if I really, really can't do it safely. Shot. Where do you feel it? In your back? Try to relax a little bit. Shot. Alright, I need to see down the axis of this disc. Huh? Yep, it is one of your sources. Shot. Let's go AP real quick. And then back to a lateral view. And I want to get the end plates lined up. Yeah, this is one of the ones we thought was going to be painful. The last one and this one. The first one I did, you didn't really feel any pain, which is what I suspected it would be at L5S1. All right, so that's good. Now we need to get this one though. But you see how collapsed the patient's left side is, the side the needle's on? Sorry, right side. I shouldn't have said left, but right. Okay, lateral shot. All right, let's get the end plate lined up a little bit better. I think we can do about a degree or two and see if we can get some improvement. Shot. Other way. Zach, you have a question?
Not yet.
That's better. That's nice. Just keep it there. So we're clearly hitting the inferior end plate. And I just want to try to shot. Well, I'm definitely in. I'd just like to be in a little bit further. You know? Shot. I think we're good. It's not. It's the best I can do, and it's definitely. Huh? Oh. No, I think it actually went a little bit more. Yeah, that's good. It's just so collapsed. Are you feeling like your back is tightening up, or are you feeling still pretty relaxed? You're okay? All right. There we go. Shot. That felt better. We're going to be able to put you to sleep very soon, okay? I just want everything to be perfect before we put you to sleep. There we go. Shot. Shot. There we go. All right. So one more. I wish I could say that it's a new record, but it's not. Right? It's not. I've done it before. I've done it before. Well, let's see if we can do it. Shot. Oh, too low. We're going to try to do everything through one incision. We may have to do two. Shot. But I'll do my best to do one, okay? Huh? Oh, it's going to be beautiful. Shot. She wants me to make it pretty. Yeah, shot. Hang in there. Shot. Yeah, I want to hear it every time. I really do. Shot. I want to know where we are with your pain control. Shot. 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 Where do you feel it? Where? Shot. Same place? Shot. AP. We're going to be ready for the laser soon, but not yet. Wow. Sometimes I can even impress myself. You did it. I don't know how we did it, but we did it. All four through one incision. We're going to do basically a surgery that would normally take most surgeons quite literally 12 hours to do the surgery. We're going to get this done in 2 hours with a 7mm incision instead of an incision from your butt to your rib cage. All right, are you comfortable? Okay, we're going to get started, okay? Well, that pain you just felt, is that your typical pain? That was the bottom disc, the one we talked about maybe not doing. Yep, I think we need to do it. It's okay. On a scale of 1 to 10, how bad was it? Just pick a number. The highest number it went. 7. So L5S1 7, it was concordant. Those are typical pain. Is it better now? Okay. You're not upset with me, are you? For making you hurt? Okay. How bad is that on a scale of 1 to 10? 9? Is that where your pain typically is? Yeah. All right. I'm so sorry. We're testing those discs to see which ones are causing your pain, and so far 2 out of the 4 are painful. That's a 10. All right, that was the one that had all the edema that we looked at. That's L34. I'm sorry. I know. I'm a bad guy right now. I feel horrible, but at least we're getting very valuable information from you. That's the one. That's L34. We're going to fix it, okay? I promise you. We're going to get it fixed, and hopefully you won't need anything else done. Are you better? All right, that's the last one. How bad is that on a scale of 1 to 10? 9. Okay, well, when you wake up, sweetheart, we're going to be all done, and I expect all that pain to be gone. Sweet dreams. Can you count from 1 to 100 by ones out loud? Out loud. All right, Zach, can you see?
We can see.
All right. For those people watching, I'm going to tell you right now, the alternative surgery to fix her back pain would be a fusion. And the incision for the fusion would be from here to here. We're not doing a fusion, don't worry. We're not going to do a fusion. Just lay down, you're fine. She's ready to get up and box with me. No, you're going to have the laser surgery done. But I want everyone to see the incision. So instead of a big surgery with screws and rods and cages and osteotomies and laminectomies, we're going to do this tiny, amazing incision. And we're going to achieve the same results as a 4-level fusion. We're going to get rid of her back pain, and we're going to get rid of her leg. She really doesn't have much leg symptoms, but some weakness. So here we go. First one, L5S1. This is the Duke laser disc repair. The only place in the world you're ever going to get this surgery, go lateral, is at Duke Spine Institute in Melbourne, Florida. We're on the Space Coast near NASA in the United States of America. For those of you watching, now that may change in the future. We're looking to open Duke Spine Institutes elsewhere in the world, but we need investors and we need some support. It's too much for me to do on my own. I got too much other stuff to do. All right. What I'd like to do is see this L5S1 a little bit better, just a little better, maybe 1/4 inch south. And then let's see what that looks like. All right, looks good. A little bit grainy, but I think we're fine. Okay, folks, we're going to get started. Dilator goes over the guide wire. We're going to, just so you all know, take a look at this. People say, do you cut the muscle? No, the answer is we don't cut the muscle. You can see the tip of the dilator is very pointy. It's like a pencil. It literally spreads the muscles apart. And I got to give credit to the people that designed this system, which is, Wolf. And I think, if I'm not mistaken, Sebastian Roiten helped design this vertebra system. Shot? But I gotta say, it's a pretty amazing system. I'm not happy. I think I put the guide wire into the wrong hole. Yep, I did. I went through the side hole when I should have been in the center hole. Us guys sometimes have that trouble. Right? Put it in the wrong hole. Go ahead. No harm, no foul. So we're good. We're right there on the back of the L5S1 disc. You can see the herniation right there. You can see it's not a big one. It's a small one. Shot. But big or small, doesn't matter. What matters is that it's causing her a lot of pain. Shot. And she doesn't want that pain. And I don't blame her. Shot. Seems to be a bigger tear than I thought there would be. Shot. Shot. All right. Guide wire out. Take it. Shot. So for those of you who've never seen Duke laser disc repair, it's endoscopic surgery at its finest. It's the least invasive surgery in the world for the spine to fix a disc problem. We don't take any bone out. We just go through a natural hole. The whole surgery is done through this tube. You can see it's 7 millimeters wide. So we're going to fix all 4 discs through this tube and a 7 millimeter wide skin incision, basically a Band-Aid incision. Shot. Some of the tools we use are a little bit brutal looking, but shot. Shot. That looks good. Let's get the scope out, the fluoroscope out. Let's get the endoscope in. Wait. Okay. So we're in L5S1. Once again, we consented our patient for this level, but I'll be perfectly honest with you. I thought this was not going to cause much pain for her. So I didn't expect to be doing it. We tested it just to see if it would be painful. And sure enough, it was. Now, I have to say, of all the 4 discs, it's the least painful of them all. But it's still painful enough that I think she would have had pain after surgery from this disc laser. And my goal is to have my patients have no pain from their spine after surgery. In other words, any kind of pain that we can fix with laser surgery, I want to fix during the surgery. I don't want to bring my patient back a second time and have a second surgery. So she doesn't want to come back either. She's actually from Canada, Alberta, Canada. That reminds me. We need a giant world map in the surgery center. Yeah, I told Karen to buy one. Well, one that we can actually put little pins on with a cork board behind it. Yeah, because we have people from all over the world that come to Duke Spine here and get their back and neck fixed. So we'd love to recognize where they come from. You have a question there, Zach?
We do. We have a viewer who's asked, can this surgery treat pain from ankylosing spondylitis?
All right, great question. Can this surgery treat pain from ankylosing spondylitis? That's a really good question. I appreciate you asking. Let's start out by talking about what is ankylosing spondylitis. Ankylosing spondylitis is a inflammatory condition that you're basically born with, where the joints in the spine fuse themselves. And that means the spine is in inflammation non-stop, 24/7. Very painful, horrible condition, very difficult to deal with, because your spine is flexible. It's meant to be flexible. You're meant to bend in your neck and your waist and twist. Bend and twist. Right? And for those of you, bend and snap. Right? I got a chuckle out of Dr. Santiago. He knows what I'm talking about. So bending and twisting of the spine is natural. It's normal. But when you have ankylosing spondylitis, your joints in your spine are so inflamed with inflammation that is out of control, that your body is just attacking its own spine. And basically all that inflammation causes the joints in the spine to fuse together one at a time over your lifetime. And as the spine starts to fuse, you lose flexibility, because those joints are just fusing to each other. So currently there is no cure for ankylosing spondylitis. It is literally a condition that is just smoldering out of control inflammation, leading to spontaneous autofusion of the spine, meaning you fuse it yourself. Can this surgery help? The answer is yes and no. It's yes because not everybody that has pain from ankylosing spondylitis has pain from the actual fusing of the joints together, because that is painful, but it's more of a kind of a dull chronic pain. What typically happens is that patients with ankylosing spondylitis can actually get disc herniations, just like this patient we're doing right now, and they can get pain from the disc herniation, in which case this surgery would work. The second thing that can happen is that they can get fractures. It's very common for patients with ankylosing spondylitis to fall and fracture their spine. And unfortunately what happens is a lot of times the doctors in the emergency room that are evaluating the patient for pain miss the diagnosis, and the patient with ankylosing spondylitis has a fracture, and that fracture is highly unstable and it needs to be fixed. So what I would say to anybody with ankylosing spondylitis, if you've fallen or had trauma and you're having a horrible pain, it's very likely that you have a fracture and you need to go and be reevaluated. If they missed it the first time, you need to be evaluated with a CAT scan. There's the tear right there at L5S1. That's why she's having pain here. It's a good sized tear. Where was her MRI done?
Somewhere else.
Not here.
Yeah,
So it was missed pretty much. By the way, a lot of the patients like this one that have surgery here for laser surgery on their disc herniation, they go elsewhere and their doctors tell them that they have small disc herniations, it's nothing, it's not causing their problem, and there's nothing that needs to be done. The reality is that the herniation is causing their problem. It's causing severe pain. And if you don't fix it with like the laser surgery that you're watching now, the Duke laser disc repair, that pain will be there for the rest of your life. The other option would be to do a fusion, but this patient didn't want a fusion. I mean, I don't know anybody who would rather have a fusion rather than this laser surgery. I've been doing this for 22 years as a neurosurgeon, and the laser surgery I've been doing for about 13, almost 14 years now. And the laser surgery is much better than a fusion. I do fusion surgery still because some people can't do the laser surgery. So they end up needing a fusion instead. That's what their insurance will pay for. Unfortunately, fusions cost a lot more money, but also they take a lot longer to recover from. So I don't know why insurance companies aren't more reasonable. I think they just want to discourage people from having back surgery altogether. Great question though about the ankylosing spondylitis. Ankylosing spondylitis is diagnosed usually with a serological marker called HLA-B27. So can this surgery help people with ankylosing spondylitis? It depends on what's causing their pain. Can this surgery, the Duke laser disc repair, cure ankylosing spondylitis? No. There's nothing that cures ankylosing spondylitis. Can this surgery that you're seeing, Duke laser disc repair, help patients that have ankylosing spondylitis get out of pain? If the pain is coming from a herniated disc or a bulging disc, yes. So again, that requires doing what's called a workup, where we would figure out where the patient's problem's coming from. Is it coming from a bad disc, or is it coming from, arthritis of the spine? Is it coming from something else? If it's coming from a bad disc, a herniated disc, then yes, we can definitely help. All right, there's a little bit of fat in the epidural space. That's the last of the tear. And again, this wasn't a big tear, so we're not going to spend as much time on this tear, but you can also see that it was a soft tear, meaning that it's not an old injury. It's not like years and years old. It's more recent. I would say this is probably at most 1.5 years for this one, based on what I've seen so far. It's not like one of those really a lot of bone spur kind of injuries that have been around for many years. This is a more recent injury. Anybody know what time it is?
13:56.
So 1:56, 2 o'clock basically?
Pretty much.
we're done here. Well, I'm really glad she talked me into testing this level. I think it's going to help her. Stand by.
Lights on, please.
I need the scope. You get a little bit of laser action in there, just about done.
Thank you, Beth.
Thank you, Beth. Beth?
Yes.
Thank you.
Okay.
All right. I'm happy with that. Take. Coming out. Scope is off, right? So we're done with L5S1, folks. We're going to move on to L45 next. And earlier we were talking about the fact that we're doing 4 discs through 1 incision. And is that a record? The answer is, it used to be a record years ago when I first did it, because I had never done 4 in 1 incision. That was a couple of years ago. But unfortunately, I already have that record, so I can't beat myself today. But it's still pretty remarkable to use a 7mm incision to fix 4 different disc herniations causing pain. I mean, there's nobody else in the world that can do that. You won't find it anywhere else in the world, seriously. Shot. All right, we're done down there at 5-1. Ready to go to 4-5, which would be this one. Thank you. Shot. Perfect. Nice job, Luis. I like it. I like what I'm seeing. Hustle. Hustle. My shoes are dry. Shot. I like what I'm feeling. I like what I'm seeing. I'm getting a really good vibe here from my team. Shot. So the other thing about her, I just point out, is that her pedicle is very short. If you look at the tip of the dilator right now, that bone just below it, there's that little run of bone, is very short. She was born with short pedicles. Now, 20% of the population, Shot, has short pedicles that they're born with. When I say short, I mean they're not supposed to be that short. Like, short is not a good thing. Short is kind of bad. It's bad. Okay, I'll just admit it. It's not bad, like really bad. It's just a problem because once they get a small herniation, you don't need a big herniation when you have short pedicles, because the hole where the nerve comes out is already too small because you have short pedicles. But you can see how the short pedicles are gonna affect the nerve in the foramen. They're gonna pinch that nerve. Shot. And you don't want your nerve getting pinched. So, mallet. Shot. What's wrong?
No, I just want to make sure I stop it.
Oh, it shouldn't be bad. Oh, that might be because I trapped it. Where's the tube?
Right here, sir.
So, the leg symptoms happen usually because of pinching of nerves in the neuroforamen or lateral recess. And the bigger the hole is, the bigger the space in that hole for the nerve root, the less likely people have leg symptoms. But something that a lot of people don't understand is pinch nerves in your back or neck don't cause neck pain or back pain. The neck pain and back pain actually come from, Shot? They come from the annular tear, Shot? And I'm the person who discovered that in the world. The annular tear is a source of axial back pain. When it's discogenic back pain, discogenic means, genesis means to create or originate. And discogenic means pain that's or something originating from the disc. Discogenic pain is pain originating from the disc. So when you have a herniated disc and you have pain coming from that herniated disc, the pain is actually coming from a very specific location. It's coming from the posterior annular tear. Basically the annular tear in the posterolateral part of the disc, either right or left. And that's what I've discovered. Now, I have to admit that there are surgeons, one surgeon in particular, who did some experiments back in the 60s. And he was operating on people's lumbar disc, and he would take a little, like a little metal stick and poke on the back of their disc, right in the foramen, while he was doing a microdiscectomy with the patient awake. That was back in the days before they had institutional review boards to review what surgeons were doing or what researchers were doing. And they were doing experiments, on people. Not bad ones, but nonetheless inappropriate without the patient's consent. So nowadays we don't do that kind of stuff. We get a board that reviews every research project and approves or disapproves. Long story short, I won't say the name of the surgeon, but he's a famous spine surgeon, and he published a paper talking about how he poked at the back. He poked all around the disc, and what he found was that patients would have localized severe localized pain to their lower back when he poked at the posterolateral disc, which is exactly where the tears are that I fixed with the laser surgery, the Juke laser disc repair. Okay? So, point, be knowledgeable in life. The more knowledge you have about what you're trying to work on or fix, the more you read, the more you learn, and understand things, the better prepared you are to solve problems. Right? So the more knowledge you have, the better prepared you are to solve problems. So what I can tell you is that that paper that I read many years ago as a resident really made an impression on me about the source of pain. And it started to all make sense to me when I started doing these laser surgeries where I was just fixing the tear. Right where that doctor was talking about pushing on and eliciting localized back pain. Localized back pain is very important. Localized means it localizes to a region, which is why the first thing I do when I see patients, besides shake their hand and say hello, is I ask them to stand up and show me exactly where their pain is with one finger. The reason for that is if they can localize their pain to an original spot, an origination center, a pain source with one finger, then that gives me a better idea of where their pain's coming from. And then I can isolate where it's coming from as a specific anatomical structure. And I know exactly what structures cause pain. Your facet joints cause pain, your discs cause pain, the sacroiliac joint can cause pain, the piriformis muscle can cause pain, the coccygeal ligament can cause pain, and then you have some weird pain sources which we're not going to talk about, like aortic dissecting aneurysms and kidneys and things like that. So you always have to be looking for those as well, because you don't want to miss a kidney infection and think it's coming from someone's spine when it's coming from an infected kidney and there's a life-threatening condition. So you got to be aware of all the different causes, and then by reading and learning you can actually synthesize new information that's useful at solving problems. So I ask patients to localize their pain with their finger. And depending on where they're pointing to, I start poking on things and trying to see what's inflamed. You can never poke on a disc. So if the disc is the cause of their back pain and you push on the center of their back, it won't push on the disc because there's too much bone there between your finger and the disc. You'll never touch it. What are you going to say, Zach? You got a question for me?
We do.
Perfect.
We have a viewer asking, do you know if this surgery is done in any other countries yet, and if not, when it will be?
So someone's saying, do you know if the surgery you're doing is done in any other country yet? And if not, when will it be? So great question. It's not done in other countries. It's only done here at Duke Spine Institute right now, because I'm the one who created it and pioneered it. And I'm still waiting for it and trying to make it go to other countries, but that takes a lot of effort and money and time, which I don't have right now. So I need help. I need more surgeons to learn. I can teach the technique to. They can learn and they can set up Duke Spine Institutes in other countries. We need funding. We need management, expertise. We need the team, the medical team, which I'm prepared to build. But there's a lot of things keeping us from being in many other countries, okay? You have to understand something about spine. When you see something like an artificial disc in your country and you say, wow, artificial discs are now available, there's a reason for that. The companies that make those artificial discs sell them for a lot of money, and they use that money then to promote that product in other places, other countries, with surgeons and hospitals. It takes really hundreds of millions of dollars to do that, which I don't have hundreds of millions of dollars. It'd be nice to think that I do, but I don't. I would just take $100 million and be happy, but I don't even have that. So to take something like this technology and bring it places, you need investment. You need investment capital, and you need a team of people to implement a successful program. And I've got a great team of people here in Florida, but I don't have a worldwide installation and development team, though I would love to have one. I'm kind of at a stage now where I'd like to see more Duke Spine Institutes helping people around the world. But right now, the United States and Florida is the only location near Orlando. It's not the end of the world if you have to come to Orlando with your family and go visit Mickey Mouse and Pluto. Donald Duck if you're Dr. Santiago. What's your favorite Disney character, Dr. Santiago?
Which one is your favorite?
Mm-hmm.
I like Pluto.
Pluto?
Yeah.
How about you, Luis? You're a Bugs Bunny kind of guy, I can tell. No?
I like actually Goofy.
Who? Goofy?
Goofy, yeah.
Oh, Luis likes Goofy. All right. Who else? Jordan. Goofy. Come on, guys. Get original here. Seriously, Goofy? That's fine. Nothing wrong with Goofy. Me? I love the Roadrunner. And Bugs Bunny.
That's not Disney.
Well, we know what I mean. Looney Tunes.
Looney Tunes.
Disney character, I guess.
Bunny is a cool guy, definitely.
I love Bugs Bunny. Yeah. He makes everything just look so easy. All right, who else has a favorite character? Mike? Don't be bashful. Who said Donald Duck? Well, you don't have a favorite of all the characters? You got to have one favorite. All right. So I'm sorry, but we don't have this surgery available in more places, but at least it's available, right? That's the important thing. This is a tear, by the way. This is where her pain's coming from, this annular tear. And we're cleaning it up. It's called a debridement. So no, this surgery is really, and all joking aside, this Duke laser disc repair surgery you're seeing is not available anywhere else. There is endoscopic surgery and transforaminal surgery, but the results are nowhere near as good as the results for the Duke laser disc repair because of the way this is done. Are there any secrets? No. If there were secrets, we wouldn't be showing you over the internet, live, unedited. We would just hide it from the world and keep it a secret, like the ingredient to Coca-Cola or Papa John's pepperoni pizza or Prime Coral's Stop RTN and Prevent RTN coral treatments. But the fact of the matter is I want the world to see what we're doing, because there's no way I can treat everybody in the world with back and neck pain, even though I want to. So other people have to learn how to do this. So we're trying to teach everyone how to do these surgeries so everyone can do it. I remember one of the biggest problems in the world is really that. What does anyone know what the biggest killer in the world is? What? No. What kills the most people in the world? Someone said cardiovascular disease. That's not true. That's only a killer in developed countries that have McDonald's. Come on. What's the number one killer of human beings? Huh? Stupidity? That may be true for a certain age group in developed countries, but that's not true worldwide. Really? I'm going to ask Dr. Santiago. No. It's close. All right, let's see. Malaria, no. Who knows? Let's see if our audience knows. What kills more humans worldwide than anything else? It's going to surprise you. I was surprised when I saw it. Any answers from our audience, Zach? In this day
Not
of
yet.
Google, shame on our audience if they don't get it. I think Zach's probably got his little fingers pumping away on his keyboard right now. What do you got, Zach?
Someone said driving.
What?
Someone said driving.
Driving? No.
And then
All right.
another person said cancer.
No, no cancer, no driving. It's actually diarrhea. So it's a D word. And it's diarrhea from a disease called cholera. Cholera, okay? Cholera is a protozoan parasite that lives in the human gastrointestinal tract. It infects our GI tracts and it prevents us from absorbing water and electrolytes into our bodies. So people die of dehydration from diarrhea. It is the number one killer in the world by far. Okay? And I'll tell you something. I saw a program a few years ago where they and what it comes from is unclean drinking water. Unclean drinking water. So think about that. Basically the poop water, diarrhea water, people are drinking it. Not intentionally, but there's so much sewage that it's basically contaminating the water source, the drinking water source in a lot of developing countries like Africa, okay, India, certain places in India. The place where the people go poo and pee is right where they get water from. And so the disease keeps infecting more and more people because everyone's drinking from there, and they'd have no clue, by the way, because they're not a developed country. They didn't go get an education or a degree at University of California, San Diego like I did. So you have all these people who have no clue where the diarrhea is coming from. They have absolutely no clue. And that's why you have the International Red Cross, the United Nations, to teach these people how to be safe, how to not die, you know? And having clean drinking water is one of the main goals for I think it's a G8 or whatever that big group of developed countries, having clean drinking water. Because by having clean drinking water, you can stop people from dying. So it's a really big deal. Anyway, someone came up with a really easy way to make clean drinking water. Anybody know what that is?
It's a small tube, like
Huh?
the small tube, like I work as a filter.
A small tube that works as a filter.
The one that sell for camping.
The one they sell for camping. Good thinking, good thinking. That's not it though. How? How? All right, you guys know what those plastic water bottles that are clear? You take one of those and you fill it with water, you know, groundwater that you drink that has cholera. You leave it in the sun all day on the top of your house, your shed, whatever they live in Africa, you know. I'm sorry, I'm not trying to be anything bad here, but they leave it out in the sun all day. And in 12 hours of sunlight, it kills all the cholera. Okay? It kills all the cholera. So quite literally, instead of just reaching down and grabbing water and drinking it instinctively, you have to wait. You have to be patient. And you have to let the sun purify the water. I don't know if it's the temperature that purifies it or if it's the electromagnetic radiation, the UV, like Luis says. I don't think they really know. But that simple little thing A little plastic bottle, water bottle, that's recycled, that's reused by someone else in a country like that can save lives. I mean, literally, millions of lives. Is incredible. So anyway, what I'm saying is if you understand the world around you better and how it works, you can solve the world's problems. You can solve the world's problems. I see kids these days, they all aspire to be the next YouTube phenomenon, the next Instagram, whatever, sensation. Dancing, goofing off.
They all dance like
When,
before.
when I was a kid, it was expected for us to go home and do math and science and read and do well in school and get A's. And I think if we teach our children to take education more seriously, we're eventually going to have all the problems of the world solved. I think education is so important to solving the world's problems. Anyway, you have another question, Zach? We're just about done here. Again, this is L45, and we're just about done. I feel like we've gotten 90% of the herniation and the annular tear. This is all annular tear, by the way. Right here, this white stuff I'm zapping away. This is the annular debridement that I was talking about. There's a lot of scar tissue right over here, and that scar tissue is preventing the disc from healing properly. So I'm just cleaning it up. It's called a debridement. I didn't discover a debridement. Debridement is something I was taught as a resident in neurosurgery and general surgery. Debridement is something general surgeons do. When there's a wound that won't heal, you debride it and it heals afterwards. So that's exactly what this is, and that's how I figured all this out. This is a wound in the disc, in the annulus, that won't heal. And there's chronic inflammation, just like there is in a skin wound or a subcutaneous tissue wound. It just won't heal. So you got to go in and do a debridement. And that's how I came up with this whole concept of annular debridement. I drew from my experience, my knowledge, what I learned. What prevents the skin from healing is also preventing the annulus from healing. It's brilliant. But see, nobody's ever thought of it. I had to be the first one. Laser standby.
Lights on, please.
Let me see, hold on.
Wait.
I think I need to get that little bit left right there. Anyway, I think unfortunately a lot of the next generation of kids is just very distracted by things that don't matter in the world. Really, they don't matter. What matters is real, in my opinion, real progress. Getting rid of disease, starvation, poverty, abuse. We have a flyer that we just got last week that we have to post in our office for everyone to see. And apparently it's the law now in the state of Florida. And it has to do with human trafficking. It has to do with human trafficking. It basically tells people that come to our medical facility, if they know of anyone that may be involved in human trafficking, to notify the police and to notify our front staff. Because even horrible people that deal in human trafficking have to bring their victims sometimes to the doctors to treat injuries. They think of those people as an investment. Just like you take care of your car, make sure it doesn't get hurt so you can resell it and so it can look good. These people treat other human beings like assets, where they want to take them to the doctor to make sure that they can still perform like an asset. It's disgusting, horrible. But having to post that sign by law, it brings that issue right to the forefront of what we deal with every day. You start thinking about it more. The injustice. All right, we're done with this disc. So,
Please.
if you want me to talk about spine things, I'm happy to do that, but you got to ask me questions. Otherwise, I just talk about what I want to talk about. Scope off. All right, I'm here for you all, the people watching the surgery. I'm here to answer your questions, to show you things, teach you things, but if you just don't ask questions, then I just talk about what I want to talk about. Right? Right, Mike?
We do have a question.
All right, 2 down, 2 to go. What's the question there, Zach?
We have a viewer asking, have you ever had anyone travel from the UK to have this surgery?
Luis is yelling in my ear. I'm sorry. What is the question?
They're asking, have you ever had anyone travel from the UK in order to have this surgery?
Have I ever had anyone travel from the UK? Of course we have. I wonder who's asking. Probably somebody from the UK, I imagine. But we've definitely had people from the UK. One of my favorite patients is from the UK. But yes, we've had people from the UK travel here. And we love our neighbors in the UK. Yeah, we stand together on so many things worldwide. Though I have to say, what's happening with Brexit? I'll be honest with you, I haven't really paid much attention because it seems to be dragging on and on and on. I was wondering, has there ever been any resolution? Is there ever going to be a resolution on Brexit? Well, how does the country feel about it? Okay, shot. Okay. Well, you see that? The needle isn't in all the way. You see that? Not the needle, the guide wire. You can actually see it within the needle. Shot. Now it's in. You want to make sure you don't put this guide wire in too far. Shot. So, but you also don't want to be too far back. Otherwise, you won't be inside the disc. And you'll take the needle out. Shot. And if you take the needle out without having the guide wire in the disc, basically you got to start over. So shot.
We have another question.
Yes.
We have a viewer asking, can this surgery treat cervical myelopathy?
Great question. Can this surgery treat cervical myelopathy? The answer is 100% yes. We do it all the time. Cervical myelopathy, what is it? For those of you who don't know, cervical is your neck or cervical spine, and myelopathy is damage to the spinal cord, or really technically it's spinal cord dysfunction is the Latin interpretation, or interpretation of the Latin. Please get a louder. Was that it? So cervical myelopathy means spinal cord dysfunction in the neck. And the most common cause is spinal stenosis, which is narrowing of the spinal canal where the spinal cord is in the center of the neck, right within the center of the spine. And that narrowing causes pinching of the spinal cord or compression on the spinal cord. Shot. And the compression on the spinal cord actually causes spinal cord dysfunction, which is not surprising. Shot. Your spinal cord is like a very sensitive cable or wire. Okay? Right? You all understand that. And wires transmit electrical signals. So your spinal cord is like a 3.5 million wires that are all microscopic. They're all wet. And they're all like basically wet pasta, cooked wet pasta. And I'm not talking about al dente. I'm talking about basically soft pasta, soft spaghetti, right? So anything hard pushing on soft wet spaghetti is going to potentially pinch it, right? And that's what myelopathy is from. It's something pressing on the spinal cord, usually in the neck. If it's cervical, it's the neck. And it's causing dysfunction of the electrical signals are not getting through properly in that area that it's getting pressed on. Can this surgery fix it? Yes, definitely. We do it all the time. So a lot of times we talk about radiculopathy, which is pinched nerves, but we also treat pinched spinal cords. As a matter of fact, the patient we did before this surgery, that was a cervical. That patient had some myelopathy. Shot. Now that is one collapsed disc space. Shot. Look at it opening up. Pretty cool, huh? There we go. Shot. All right, so it's time to get the guide wire out and let Luis straighten it out. I'm not ready yet. I want to advance the dilator. Nice. There we go. Tubular retractor. Pretty incredible, huh?
May suffer.
What?
The tubular retractor may suffer in this space.
Yeah. Dr. Santiago has become quite an expert.
We have
We're not
another.
far from understanding everything about this procedure. I'm not saying you're ready to do it yet. Well, you're closer than most people. Is there a question, Zach?
We do. We have a viewer who says, I have a small central disc protrusion, mildly indenting the thecal sac, small amount of pain at location, no pain yet going down the leg. What would be the best treatment at this time?
So you got a small central disc herniation and no leg pain, they said? No leg symptoms? Is that what they said?
Yeah, small amount of pain at location, no pain in going down the leg.
No leg symptoms or no leg pain, no leg symptoms, small herniation. So my big question is, why do you need the surgery or why do you need treatment? And it doesn't sound like you do unless you're having a lot of back pain. So if you're having back pain that you want to get rid of, that would be the reason to have this surgery done. If you're not having any significant back pain, and of course you already said you're not having any leg symptoms, there's no reason to get any surgery done. But if you want to get rid of the back pain, then that would be the reason to do the surgery. Shot. So if the back pain doesn't bother you that much and you're happy to live with it, then I would not do surgery. If the back pain gets worse and you want to fix it, then come here and we'll do a laser surgery. This laser surgery will be your best surgery.
Suction on.
All right.
Lights on, camera on.
Now, of all of her discs, this was definitely the most painful. I think she rated it, what, 10? Was it a 9 or a 10? Something like that.
No, she has so much edema around those two end plates. That leg.
She has a lot of edema, she does. That's just the collapsed disc, the scoliosis. Look how scarred it is. You can already see. That is not a soft disc herniation. That is like, I don't even know how to say it. It's like very thick and collagenized. Been there a long time. It's been worked on by the inflammatory system. All right, I can't get that without the laser. So I hope I was able to answer your question to your satisfaction. But if you have a disc herniation in your back or neck and there's no nerve compression symptoms or findings on exam and there's minimal pain, I would leave it alone. Would not recommend treating it. But here's what really happens, to be honest with you. For those of you listening, I might as well say it. Is when you get that herniation and it starts causing pain, most people don't want to deal with the pain every day. So what they do is they start to limit their activities. They start to take it easy. Maybe if they love golfing and that pain comes with golfing, they'll stop golfing, or they'll stop doing the things they like to do to avoid getting in pain. And that's a personal choice. Do you want to live your life and enjoy it, or you want to and get rid of your pain, or do you want to live your life of trying to avoid pain? Right? Ticket. I personally, I don't mean this in a bad way, but I don't see the point of living life if you're not enjoying it. You understand? Why is I don't see, and I don't mean that like, oh, time to end my life. What I mean is it's time to get your back fixed or your neck fixed. Don't let the pain ruin your life. We don't know how many lives you have, right? I don't want to have any arguments with anybody about religion, but I'm trying to be open-minded. I mean, I have my beliefs, but certain people believe you have more than one life. But most people believe you have one life. So if you have one life, you might as well enjoy it. Why? And even if you don't want to enjoy life, that's fine. But if your back pain is keeping you from doing things you want to do, whether it's enjoyment or not, maybe it's work. So why would you want to live with back pain? You shouldn't. There's no reason to. You don't have to anymore. Light down. There's the tear right there, folks. Not much disc left here, right? It's like totally collapsed. So everybody says to me, if the disc is collapsed, what are you fixing? I mean, are you putting a new cushion? No. I'm not putting any cushion. I'm just taking this little thing right here out. That is the annular tear. I'm debriding it. I'm removing it. I'm cutting it out with a laser. By doing this, it cures the back pain. Why am I teaching you my secret? Because whether or not you go to Duke Spine or not, I want you to know the truth. You won't be able to find anyone else to cure it unless you fuse your spine, or fusion might work. Depends on who does it. But the best is this right here. No fusion, no metal, no hospital stay. This patient and this surgery you're watching is outpatient. We're doing this in an outpatient surgery center. We're not at the hospital. I don't believe in going to the hospital for procedures that don't need to be done at the hospital. The hospital would be the worst place to do this procedure besides maybe a garage or a living room. But hospitals are where you go if you have an infection. You go to the hospital. Hospitals, unfortunately, have lots of potential sources of infection. And the last thing in the world you want to do is go in for an elective spine procedure and come out with an infection. That happened to me personally. I went in for a procedure, and I thought I'd be back to work the next day. I was a resident at the time, and I ended up with an infection. Mine wasn't a spine procedure. I had a hernia repair with mesh, and I went to the best that there was, and I still got an infection. And I had to be on vancomycin for 4 weeks. I couldn't work. And not being able to work was the worst part. Because as a neurosurgeon, when your colleagues are all putting in 110, 120 hours a week and you're laying in bed, you feel badly, like you're not doing your part. And they would come by and joke with me in the hospital while I was admitted. They were so kind. They came by one time, and I was asleep, and they put 2 gloves, and they put a Ducalax enema kit right next to where I was laying, so I could see it when I woke up. In other words, like, get ready for the enema. The nurse is coming back to give you one. I'm like, why would I need an enema? And I found out it was my friends playing tricks on me. But anyway, I think they were really trying to say, get your ass out of bed and come back to work so we don't have to do your job too. The point I'm trying to make is, when you're sick with back pain or neck pain and you're not able to go to work or do your job properly, you're not able to take care of your family, prepare meals, bathe the children, keep your significant other company, doing fun stuff, what's the point of living? If you have to live in an armchair, where's your dignity? Get your back fixed, get your neck fixed, and stop being a victim. I'm a very empathetic person, but I'm not empathetic to people that can help themselves and they don't. I was brought up a strict Baptist, and as a strict Baptist, you're always asking God for permission for everything that you do. You see that? You see that herniation just slip out? Isn't that cool? That is a herniation that's been worked on for a long time. It looks like a river rock. Really smooth. Stand by. It thought it could sneak out and get away, you know? I was like looking somewhere else. So even the Baptists believe God helps those who help themselves. Right? If you want to get the most out of your life, you have to make an effort to do just that. And when presented with a solution, an opportunity to solve a problem, you should. Those are all veins, by the way, and there's a little bit of epidural fat. We're not here to mess with those guys. Those are normal. I'm just here laterally, trying to get the last of this herniation. This is like kind of a lateral herniation. This is the level that has a little more rotation, rotational abnormality, so lateral listhesis and lateral stenosis. This is all foraminal. I just want to make sure I get all this foraminal stenosis. It's mostly calcified and very thick and hard. What time is it?
2:39.
All right. All right. I think we're done here. Take. Let's see if we can see the nerve root.
Lights on, please.
It's in there. Hold on. I want to get that thing right there. It's a little more grunge. Shouldn't be there. It's just underneath the nerve root. It's kind of bone spurish. See the yellow, gold? It's calcium. All right.
We have a question.
Of course.
We have a viewer
Stand
asking, is it possible to have this surgery at the same levels you had a fusion at?
All right, so someone's saying, is it possible to have this surgery done at the same levels you had your fusion on? The answer is yes, it is. However, there would have to be really good reason for it, for me to do that. In other words, you'd either have to still have a pinched nerve, scope off. You still have to have a pinched nerve where your fusion was done, which by the way is pretty common. A lot of spine surgeons that do fusions, they don't do decompressions first. A decompression means taking the pressure off the nerve. So if you go to most spine surgeons these days and you have a pinched nerve in your back or neck, they actually won't unpinch your nerve. They'll just fuse you right where you are, which is why a lot of people come out of spine surgery and a fusion and they're worse off or they're the same as they were before surgery, which blows me away because I was taught if you have a pinched nerve, you unpinch it during the surgery. That's part of the surgery. You have to do that. That's your main surgical objective. But what amazes me is there's so many spine surgeons that don't understand that. And they treat spinal stenosis with fusion. And you should never treat spinal stenosis with fusion. You should treat spinal stenosis with decompression. Decompression means taking the pressure off. And you may need to do a fusion because your decompression destabilizes the spine, so the patient needs a fusion. But the fact is that if you do the Duke laser disc repair like we're doing right now, you don't need the fusion because we're not removing any bone. We're not destabilizing the spine while we're doing a decompression. So to answer your question, I'd need more information. I wish I could give you a better answer right now. Shot? No, I would say kaknud. I need that out of the way. Shot? Interesting, right? Shot? It must have come out a little bit, but we're okay. All right.
We
Shot?
have another question.
I hope I answered that question well. Well enough for our viewer.
We have a viewer asking, what is the chance that the
Shot.
disc herniates again after surgery?
So one of our viewers says, Dr. Duke, this is a nice surgery, but what's the chance you're going to get a recurrent herniation? Like get another herniation after the surgery? Great question. Fortunately, we already have data on that. Sean? The answer is 1%. 1% chance. Sean? And that's based on my own patient data. Sean? Shot. So I've done 1,000 of these laser surgeries, and in that 1,000 I've had 10 patients that have re-herniated at the same place I operated. If I did 3 discs, they may have re-herniated at 1 or 2. That doesn't mean they re-herniated all 3. Most of the time, when people re-herniate, they usually re-herniate at 1 disc. Or maybe 2 at most, but usually 1. So if I did 3, then that means 1 of them is bad again or 2 of them is bad. But I've never seen all 3 go bad. Long story short, it's a 1% chance per patient. And that's what I tell my patients. They have a 1% chance. And because that's the data, that's the fact, that's the truth. I'd like to say it's 0, but it's not. And I will tell you this though, Shot. The patients that have had a recurrent herniation have it's always been because they've done something they shouldn't be doing. I'm looking for a shot. I need a shot, yeah. In other words, they didn't follow the instructions, is what I found almost every single time. Shot. So the instructions are simple. Shot. Don't lift over 25 pounds for the first 6 weeks. Shot. Don't bend over and pick things up from the floor. Bend at your waist. You don't want to do that. You put a lot of pressure. Why do I feel hands between my legs? You're trying to distract me? All right. Thank you. I know you're trying to keep everything dry. I appreciate it. But I don't want to step on your arm either. If I stepped on your arm accidentally, it'd be bad. Because I weigh like 250 pounds. Of course, 200 of that is my brain, right? Dr. Santiago's laughing at me. If I could make 200 pounds of my weight, my brain. Yeah. What do you think would be the biggest problem I'd have? Anybody? My brain was 200 pounds. All right. So, right. That would definitely be a problem. But let's say I lay down all the time. Like in that movie, Dune. Right? That giant creature. That was all brain. Floating in a machine. By the way, one of the best movies I've ever seen, Dune. Great sci-fi. The biggest problem I'd have is what? Santiago. Time for a higher level answer. An anesthesiologist.
There's a lot of
right? Brain gets most of the blood, 20% of the blood supply anyway. But what does the brain have that's the brain, the energy consumption of the brain is massive. It's like a massive supercomputer. So a 200-pound brain means I would have to eat like 20,000 calories of food a day. And I wouldn't have a GI tract to support it, right? So it'd have to be TPN, direct hookup, continuous infusion of nutrients. Okay, sorry. That's what happens when you start talking about things with a neurosurgeon. You get crazy ideas. Our last disc, and our patient is almost home free. How is our first patient doing? Are they ready to go? Yeah, let's find out. So this is the final disc. This is the L23. And once again, we tested this disc as well before we started the surgery. And indeed, it was very painful for our patient. So that's why we're fixing it.
We have a question.
Sure.
We have a viewer asking, are there any
A little bit
exercise...
louder, Zach. I'm sorry. We can't really hear you.
They're asking, are there any exercises or other recommendations you would have to prepare for having the laser disc surgery
Are there any
beforehand?
exercises that you can do to prepare for the Duke laser disc repair? First of all, excellent question. The answer is yes. So anytime you're thinking about having surgery, it's like thinking about going mountain climbing, okay? You've got to prepare. And being fit, diet, nutrition, very important. You want to have a well-balanced diet. You want to have lots of fruits and vegetables. You want your vitamin and mineral levels to be optimized before surgery so you can heal properly afterwards. As far as exercises go, there's definitely the need to improve your core muscle strength, because I'm not, as a surgeon doing surgery on your spine, I'm not fixing your muscles, I'm fixing your disc. And the muscles themselves frequently are out of shape in our patients because they have so much disc pain, they really haven't been doing any activity. So I strongly recommend people engage in some type of a therapy program, but I will tell you this, most will complain that it hurts. And they're right, it does hurt. It just hurts too much. You know, people with back pain are usually not in great shape because it hurts to do things. It hurts to be active. And so that's created this false belief that people with back pain who are fat, they have back pain because they're fat. No, they're fat because they have back pain. So when your back hurts because you do anything, you're going to not want to do anything. So you're going to want to sit around on a couch and avoid pain. So if you're asking, are there exercises you can do? The answer is yes. Any type of aerobic exercises, stand by, such as speed walking, yoga, low impact aerobics, stretching, massage. Those are all really good preparation for surgery if you want to do something. Okay? But the truth is whether you do those exercises or not, we'll still fix you. We'll still fix your spine. And you're going to need to do those exercises when you're done, when you go home. So doing them ahead of time doesn't prevent you from needing to do them when you go home. There's the tear. You guys see the tear? Isn't that amazing? And the blue stuff is the herniated disc that's stuck down. Not much left of it. It's been melted away. Little fragments coming out. And my job is to clean up this tear, debride it. That's what the Duke laser disc repair does best. No other surgery in the world does. Debriding the annular tear. By the way, we have at Duke Spine Institute, the best long-term data on any endoscopic spine surgery. We have a 6-year average follow-up for our patients having Duke laser disc repair, the surgery you're watching for their lower back. with 95% relief of back pain that they had before surgery and leg symptoms they had before surgery. One thing I should talk about, which unless there's another question you want me to answer, Zach.
Not yet.
Okay. One thing I'll talk about that I think is very important for people to understand is that back pain and neck pain have different sources. In other words, there's not one source of back pain and one source of neck pain. In other words, this surgery that you're watching right now doesn't fix every single type of back pain there is. For example, if you're having pain coming from something called the sacroiliac joint, that's really where your tailbone meets your hip bone. It's the bottom of the spine where the tailbone connects to the hip bone. That joint is called the SI joint. There's a right and a left SI joint. This surgery you're seeing right now will not fix that pain. So it's very important for people to understand that the cause of their pain requires a specific treatment. And we can tell you what the treatment is once we know what the cause of your pain is. But a lot of people will have one source of pain fixed. For example, they may get their sacroiliac joints injected and treated with therapy and the pain goes away, but then 6 months later they get pain again. But it may not be from their SI joints, it may be from the piriformis muscle, or it could be from a herniated disc, it could be from the facet joints. The point is, every time you have pain that's different or new, you need to come in and be assessed to see what's causing it. Now, most types of pain are fixable, curable. In other words, you don't have to just keep managing the pain. You don't have to keep coming in for shots. We'll try shots frequently to see if they'll work. Sometimes shots will give you long-term relief for several years, but most of the time shots only give you several months of relief. Surgery, on the other hand, can give you years and years of relief, if not a lifetime of relief. So what's important is that you give me a chance to figure out what's wrong with you and to tell you what can be done to fix the problem. And once we fix a problem, don't expect that fix, laser standby, to fix every single problem that you ever have with your back, because you've literally got 20 different pain sources in your back. And if I fix 2 of them, you still have 18 things that can go wrong. And don't expect my fixing of 2 to fix all 20. That's unreasonable. We just can't do that as doctors. If we did, I'd be operating on people nonstop, and they wouldn't get any better.
We have another question.
Yeah.
We have a viewer saying, on my MRI report, it mentions a transitional lumbar sacral junction.
Yep.
What is that?
All right. So first of all, Zach, can you have Sandy make another pot of coffee, please?
Yes, sir.
I'm just about done. What's happening with the person's MRI? Someone's saying I have a transitional lumbosacral junction. What that's saying is the lumbar spine is mobile. It has bones and it has joints between them so that those bones can move. The sacrum, on the other hand, is solid. One solid piece of bone. Doesn't move. No joints. So what they're saying is normally you have 5 lumbar vertebrae and you have a disc between each one of them and between the 5th lumbar vertebrae and the sacrum. What they're saying is that one of those discs in your lumbar spine is not a real disc, the bottom one. And it's really just those bones are fused together, kind of like the tailbone where there's no movement. That's really what they're saying. So nothing for you to do about it, but it's important when I plan surgery to know if there's sacralization of lumbar vertebrae. So this is our last disc, as I said to you before. We're pretty much done, and we're going to wake this patient up, and I expect all the pain she had before surgery will be gone. That's what I'm expecting, because we found that there are 4 discs that caused her pain, and I'm taking care of the parts of the disc that I know are causing the pain, which is the annular tear in the back of the disc, right where we're looking at. That's the back of the disc. We're quite literally looking at the back of the disc right now. And right here is where that painful tear is. And this is the 4th disc that we're fixing. She's already had 3 fixed so far in the surgery, and this is the last one. So when I'm done with this, we're going to be done with the surgery. We're going to wake her up. She'll take an hour to recover and wake up, and then she's going to go home. She's here with her mother, and they're visiting from Canada to have the surgery done. So tomorrow I think she flies back to Canada, but we'll see her in the morning in the office, check on her, make sure she's doing good. All of our patients have access to us anytime they want. They can just call Duke Spine and get a hold of us. I give all of my surgery patients my cell phone number so they can call me anytime if they need me. I believe in being accessible to patients. Just not on Facebook. Just kidding. That was a joke. Everybody's getting tired. Standby laser. Just gonna get that little piece and we're done. Any other questions?
Not yet.
All right. So I'm gonna finish up here and then I'll head over to the conference room. And in the conference room, we can answer any other questions our audience might have. That's good. Great job, everyone.
Right on, please.
Pretty cool stuff, huh? If you were to tell me as a resident in neurosurgery that I would be doing endoscopic laser surgery in the future, I would have said, you're crazy. I would have said, there's no way. I don't know how to do it now.
Look at you now.
Look at me now.
That's all you want to do.
Training wheels are off. All right. I'm going to come answer questions, so go ahead and type them up. A little bit of pressure. Oh, wait, let's show our audience the incision. Okay? Zach, are you ready?
Yes, sir.
All right. The incision is right here, folks. Look at that. 7 millimeters. The whole surgery was done through that. It's incredible. And all of it was done with the endoscope. Good stuff. Pressure. Thank you, everybody. Good work. I'm coming over to the conference room and we'll answer some more questions. Good job. Yeah, L5S1, 7 out of 10. Glad we did it. This is Dr. R. Dugmajan. I'm returning back to you now that I've gotten out of the operating room and I've seen my patient in pre-op. And our first patient is gone. They already went home. So it's good, but it's also bad because I was hoping to interview him so you could see. That was the 3-level anterior cervical Duke laser disc repair, 3 disc herniations in the neck with pinched nerves, weak arm. His strength had already come back in his bicep, but his deltoid was still weak, and he was doing fantastic. So we just finished up our second patient, a young lady from Canada, and now we're getting ready to do our third patient, and she's going to be a 2-level Duke laser disc repair, L4505S1, for back pain and primarily her leg. Her leg is weak, numb, she can't feel it. She's got pinched nerves at L45, L5S1. She's got weakness with drop foot. And she asked me, when can I be back to normal? That's a great question. When can I be back to normal, doctor? I'm going to have surgery today. When can I be back to normal? So the answer to that question is not the same for everybody. Depends on what your problem is before surgery. If your problem is a drop foot, it's going to take months, if not a year, or a little bit longer than a year to get your strength to where it's going to be the best it can be. But you need to have the surgery to unpinch the nerve so it can start healing. Once the surgery is completed, the nerve is unpinched, the healing process starts. Until you have that surgery to unpinch your nerve, the nerve is going to continue to get crushed, continue to get damaged, and your symptoms will likely get worse. By the time you have atrophy of your muscle, that means the nerve has been pinched for a long time. Atrophy does not happen overnight. Atrophy, for those of you who don't know what I'm talking about, means a wasting of the muscle. So if you have normally big bulging muscle and the nerve gets pinched hard over time, usually it takes months if not years, the muscle will shrivel up and get smaller and smaller. So on the one side of your body that's unaffected, you're going to have a big muscle, and on the other side that's affected, you have a small muscle. And the smallness of the muscle is due to a process called atrophy, where you're wasting away or wasting out the bulk of the muscle due to innervation, or a lack of innervation, I should say. You don't have any innervation of the muscle. Muscles need constant stimulation from nerves in order to maintain their tone and their bulk and health. So when you have a pinched nerve and the signals aren't getting through from the mind to the muscle through the nerve, your muscle will get small on its own. Okie doke. So our first question, Zach, was...
Are you able to treat non-sequential disc herniations in the same surgery with the procedure?
So one of our viewers says, Dr. Dugmajan, with this Duke laser disc repair procedure, I like it, but my herniated discs may not be lined up one after the other. There may be a normal one in between them. Are you able to treat abnormal discs, herniated discs, but ones that are separated perhaps by a normal disc or two? In other words, they're not contiguous. The answer is yes, we can treat them even if they're not contiguous, no problem. If you're asking, can we do your neck and your back at the same time, the answer is no. We don't usually do that unless we absolutely have to, but we prefer not to. It's not so safe. But some people don't give us the option. They say, I don't care what it is, just do it. I'm kind of like that when I talk to my doctor, which is why I don't have any doctors, because they kick me out of the office and say, you're too bossy. Just shut up and do what we tell you to do. Anyway, the answer is yes. We can treat non-contiguous disc herniations in the same surgery as long as it's in the same part of the spine.
Can you explain what sacroiliitis is and what the best treatment for it would be?
Great question. So someone is saying, Dr. Dugmajan, you mentioned this term, sacroiliitis, and I've heard it a couple of times, not really sure what it is. Can you explain what it is and what the best treatment is for it? So let's think about it this way. You all know what the spine is, right? It's this really bones stacked on top of each other. The bones are called vertebrae, and they're literally stacked on top of each other, kind of in a way like Lego would stack on top of itself. And you have all these vertebrae in the neck and the thoracic and the lower back, and they literally make a column when they stack on top of each other. That's called the spinal column. But to maintain flexibility, God gave us joints in between the bones, and those joints move, and so we want to maintain that flexibility, right? Well, that flexibility carries on down the spine to the bottom of the spine, where the tailbone, which is the last quote-unquote vertebrae called the sacrum, it's a bunch of vertebrae fused together, so there's no flexibility within the sacrum, but the flexibility is between the sacrum and the iliac bones or hip bones where it attaches. So all that weight in your arms, your head, your chest, all the organs inside your innards, is all that weight is transmitted to the spinal column, from the spinal column to the hip bones through two joints called the sacroiliac joints. And these joints are important because they cause pain in adults and young people, and that pain can be severe, debilitating. It can keep people from doing what they normally like to do, keep them from working, keep them from enjoying life, keep them from doing sports, whatever. That pain is horrendous. So at Duke Spine Institute, all we treat are patients with back and neck pain. And we literally have tens of thousands a year that come through our clinic and get help, which is why we have a big team and a lot of people. We have great people. But anyway, with those tens of thousands of people, we have really tens of thousands of pain sources, right? But if you really think about it, I told you earlier in the broadcast that back pain has about 20 different causes. So one of those causes is sacroiliitis, which is inflammation of the sacroiliac joint, sacroiliitis. Iliitis means inflammation of the joint. And that inflammation is no different than arthritis in any other joint of your body. So they've got inflammation from arthritis in a joint that connects the tailbone to the hip bone. And it's basically, if you know where your butt crack is, think about the top of your butt crack right there and go to the side, like 2 finger breaths, at most 2 finger breaths, usually 1 to 2 finger breaths to the side of the butt crack. And that area is the sacroiliac joint. You can probably feel the ridge of it. Anyway, sacroiliac or sacroiliac joint dysfunction or sacroiliitis is when you have inflammation from arthritis in the SI joint and it causes horrible lower back pain just to the side of your butt crack. It's very tender when you sit. It hurts. The treatment, the best treatment in the world, is really therapy combined with injections in the sacroiliac joint with Novocaine. And if that works, takes the pain away, you go do therapy and break up the scar tissue, get the joint mobilized, get the joint out of pain, and rehabilitate the joint by stretching and moving and all that stuff. Now, if that works, but the pain comes back, the next thing you can do is PRP, platelet-rich plasma, and stem cell injection in the joint. And that works really good about 80% of the time. The next thing you can do for sacroiliac joint dysfunction is you can do a rhizotomy, where we go with a needle and bone the pain nerves to the joint, just like we do with the facet joints. And finally, you can fuse the joint, so you can put nuts and bolts across the joint. So there's lots of things to do for sacroiliac joint dysfunction, but I will caution everyone at this moment. Lots of doctors are diagnosing sacroiliac joint dysfunction or sacroiliitis incorrectly. They're saying you have it when you really don't. They're not doing it necessarily intentionally. Some of them are. Some of them are absolute scumbags, and they're trying to lie to you so they can do a fusion surgery on you. But the reality is it's misdiagnosed most of the time for a variety of reasons, and I won't get into those reasons, but they're complex. But just understand, if someone's telling you you need a sacroiliac joint fusion, come see me first before you do that. Don't just jump into it. I will tell you whether you need that sacroiliac joint fusion or not. Or don't listen to me and just go get it done and be miserable. Next question. Can sacroiliitis cause radiculopathy beyond the knee? The answer is 99.9% of the time, no. But there is a small chance that sacroiliitis can cause inflammation anterior to the joint in the pelvic area where the nerves are that go down the leg. But it is extremely rare, and you rarely ever see anything like that. So the textbook answer is no, sacroiliitis cannot cause radiculopathy. You don't get radiculopathy with sacroiliitis. That was our last question, and we have one more surgery starting in about 30 minutes, so hopefully you'll join us.